Thank you very much for the kind introduction. It's a huge honor for me to be here. I wouldn't consider myself a world expert by any means, but I am an enthusiast. So it's nice to go and share some ideas with you. So when Tapas and colleagues from the Nephrocritical Care Society approached me, I thought I'll do something slightly different from my usual talk, and I came up with this. So in terms of my conflict of interest, I do work in the NHS as a consultant in critical care. I have some research activities with King's College in London, and I sit on the execs of the International Fluid Academy. But probably my biggest bias is that I believe that anyone who looks after a sick patient, be it on the intensive care unit or in the emergency department, he or she should be able to do some point of care ultrasound. And so the premise of my talk is to assess the circulation, in particular with that of using ultrasound in the next 25 minutes or so. So although this talk is around perfusion, I think it will be good to start with the absolute basics, in the sense that whenever we talk about acute kidney injury or suspected acute kidney injury, ultrasound examination is recommended. So if you look at our KDIGO guidelines, they recommend a ultrasound examination. But I would say that the ultrasound examination that is advocated is around the anatomy. And so you want to rule out any form of obstructive uropathy. So classically, we divide AKI into pre-renal, renal, and post-renal. So to most people, inside and outside of intensive care, the ultrasound is there to rule out the post-renal. So you may see something such as this one. So this is a gentleman, it's a ultrasound scan of the bladder. And as you can see, there are fragments, bits and bobs within that bladder. And this is someone who's unfortunately has a bladder tumor, bled, and developed obstructive uropathy. The other thing I would advocate using the renal ultrasound for is it may be the first sign that someone presents with acute kidney injury on a background of chronic kidney injury. So in this one here, you can see that there is that's the liver. That's a very, very thin, I can bring my pointer up, a very, very thin cortex around a very, very small kidney. So this might be the first presentation of acute kidney injury in someone with chronic kidney disease. The thing that should not be missed, though, are images such as this one. These are examples of hydronephrosis, ranging from mild hydronephrosis, moderate hydronephrosis, and severe hydronephrosis. These require immediate, timely intervention. Very easy to pick out. You don't necessarily have to get the grading system right. There are a couple of grading systems out there. You just need to know that it's there. If you're not sure whether it's moderate, severe, you need to ask a friend, and that's usually in the form of a radiologist. Okay, so this is just to reiterate the type, the mild, moderate, severe. And as you can see, compared to the normal kidney, this is a big hole, big black hole in patients with hydronephrosis. This is just another example of patients with hydronephrosis there. This is an interesting one. So this is an example of polycystic kidney disease. So they generally present in younger patients. And again, the acute kidney injury may be the first presentation of an underlying more chronic condition. Okay, so that's the anatomy bit done. Let's talk about what we're meant to be talking about, which is perfusion. So simplistically speaking, whenever we look on the intensive care unit, fortunately, unfortunately, rightly or wrongly, we have generally been focused on the arterial side of things, the arterial perfusion, flow into the vital organs. And we do that by concentrating on things such as the MAP. We say, we're interested, I want a target mean arterial blood pressure of 60, 65, 65, 70, so on and so forth. There are obviously there's sort of presumptions we make along the way. We presume that if you've got a decent blood pressure, decent MAP, that you will be perfusing your kidneys well. Broadly speaking, there are already problems with that because we are assuming that a pressure number translates to a perfusion number. Now, measuring perfusion is much more difficult, so we make that assumption. The other assumption that we make is, unfortunately, we also concentrate less on the venous side of the circulation. So why is that important? Because simplistically, your perfusion pressure of your organ, so let's take the kidneys as an example, is simplistically the difference between your arterial side and your venous side, or in specific cases, the difference between your arterial side and your intra-abdominal pressure. That gives you a perfusion pressure. But all too often, we just concentrate on arterial pressure and not necessarily to flow. One of the main challenges of this trying to work out flow is that it's quite difficult to measure compared to a blood pressure, be it non-invasive or invasive. That again relates to what we do in terms of fluid therapy. So this is a shout out for the International Fluid Academy. Whenever we talk about hemodynamics and perfusion and low-less fluid challenge, we have this sort of curve in our head. And this is your Frank-Starling curve. And the idea is that you move your cardiac output, or more strictly speaking, your stroke volume, up the responsive bit of the curve and hopefully avoid the flat bit of the curve, and certainly avoid the more distal part where the cardiac output falls off when you give too much fluid. So the reason why I'm advocating ultrasound is that I'll show you that there are ways and means to assess flow rather than pressure. And you can look at whole body flow, i.e. from the heart, versus kidney flow, so flow into the kidney itself. And you can sort of thinking about the idea of the macrocirculation versus the microcirculation. And again, I'm going to show you a couple of different techniques that you can use, especially when it comes to imaging the kidney. So let's take a look at whole body macrocirculation as well. So again, we'll start with the arterial side. We'll start with the heart. Now, most of you I know can already do some form of critical care echocardiography. And again, like I said right at the start, my bias is that I think anyone who looks after a sick patient should be doing something like this already. So these are very standard parasternal long axis, parasternal short axis, apical four-chamber, subcostal four-chamber view. I've intentionally chosen very, very simple, non-complicated images because I think when it comes to echocardiography especially, there's a danger to overcomplicate things. And you already gain a lot of information just by looking at a good quality 2D image. You can judge the size of the ventricles, whether they're large, normal, or small. You can judge systolic function of the left heart and the right heart. Of course, you can do complicated measures such as ejection fraction, BTI, so on and so forth. But actually, qualitative assessment, whether the ejection fraction or systolic functions visually looks good, normal, or poor, is very, very helpful already. So for example, in someone who you're thinking whether this venous pressure might be up or right-sided pressures might be up, that probability is increased just by seeing a dilated right ventricle compared to the left ventricle. That probability is increased if you see that the TAPSE, tricuspid annular plane systolic excursion, is down. No complicated measures. So take a look at this heart. Parasternal short axis, it's not moving very much. So if you see this in the context of someone with an acute kidney injury, you would wonder whether the acute kidney injury is because the kidneys are not being perfused appropriately. Similar to this one. That's your left ventricle. You can see the papillary muscles there. Again, not moving very much. Now look at this one. Left heart over here, right heart over here. You can see in this one, your right heart, if you're very generous, might say it's equal size compared to the left, but I think it's bigger. So this is an RV that's dilated, an RV that is impaired. Okay. So when we look at the arterial side, we talk about fluid responsiveness. I'm sure you'll cover this in future sessions, if not later on. We've moved away from static single measures onto more dynamic measures. Echocardiography is certainly one of the ways you can assess fluid responsiveness. Probably the one that most of us use in the critical care fraternity is the measure of left ventricular outflow tract, VTI. There are other things that you can do, but I genuinely think this is probably the easiest to do, most accessible to do. A reference there for all those who are interested. Another paper there that talks about the velocity time integral. And it's just essentially using your pulse wave Doppler to measure flow in the left ventricular outflow tract. You can trace the trace or outline the trace, and you get a number. Normal is above 15. Okay, it's not so much the number, it's the response to therapy that becomes important. So if the number is 12 and you give a fluid bolus and the number goes up to 18, they say 15% is considered fluid responsive. That's a measure of fluid responsiveness. If you're very, very clever, I put this in just to highlight the potential direction. This is a software, this is GE, but other software manufacturers have got something similar. Now, there are software out there that will actually allow the machine to do the VGI calculation for you, provided you get the view. So provided you get the apical 5-chamber view, the machine itself will pick up a VGI and do the tracing and calculation for you. Very clever. Okay, so that's the arterial side. Let's look at the venous side now. So simplistically speaking, whenever I assess someone's venous circulation, I always start with the right heart, and I always start with diastolic as well. So this is what the sort of things that you can do to assess diastolic function or dysfunction, things you need to know. This is not necessarily in the advanced skill set. So those of you can do it, great. Those who can't do it, it does require training. It is not core competency. Other thing, I then move on to the IVC. So simplistically speaking, I'm sure you're all aware, big IVC, full, empty IVC, empty. The problem is that I don't think the IVC, when it's in the gray area, is helpful. You need to look everything else. People like it because it's simple, but because it's so simple, you probably need to be aware of lots of caveats around it. Okay, this is a good paper covering what I've just said, which is the situations in which the IVC is perhaps less than useful. Okay, on to the more interesting stuff. Most of you who are in nephrocritical care group, I know, has heard about the concept of venous congestion. This is the original paper, which I put up here for people to QR code, download, and so on and so forth. And it was developed by colleagues mostly around in Canada. And the idea of it is very, very simple. Certainly, it's a very nice idea. And what it essentially says is that, I think I've got a summary here, When your venous circulation, right-sided circulation, becomes fuller, the first thing that will happen is your IVC becomes full. When your IVC becomes very, very full, it means that the veins that normally drain into your IVC will start have abnormal flows. So for example, if we take your hepatic vein, which normally drains into your IVC, as you become fuller and fuller, normal flow, which is in the direction of the IVC, so below the baseline, starts becoming more and more abnormal to the point that it reverses. This is exactly what you see as described by the scoring system. So instead of flowing easily into your IVC, the flow ultimately reverses. Take the portal vein, such that the flow within the vein is usually continuous, minimal variation. As the systems get fuller and fuller, it becomes more pulsatile. The renal vein, and we'll spend a bit more time looking at it, it is the intraparenchymal renal vein and not the main renal vein itself. Because the vessels are so small, if you put a Doppler box over it, you can get the arterial flow on the top, venous flow at the bottom. The venous flow is normally continuous. And as your systems get fuller and fuller, it becomes more and more discontinuous, almost pulsatile. And you put all these things together, you can have a grading system there. So that is the premise of the VEXAS ultrasound score. So I've talked about the artery, I've talked about the vein, venous congestion. Let's look at the kidneys itself then. That's the whole body. You can simply put a color Doppler box over the kidney. Your kidney, as you know, receives 20–25% of your cardiac output, so the whole thing will light up. Okay. You can then measure the renal resistive index of various different arteries. You can do it within the parenchyma, which I've shown you, which is what's advocated in the original VEXAS score. But I know some of you work in kidney transplant centers, and so if they're worried about the graph, what your transplant surgeons will want to do is to look at the main, the transplanted or grafted renal artery and look at the renal resistive index. Normal is about 0.7. If it's elevated, so above 0.7, 0.8, 0.9, it probably means that perfusion to your kidney is impaired. So these are examples. So this is what a normal resistive index should look like, what you expect, like in your arterial waveform. And this is one where the renal resistive index is elevated. So you can see a much sharper upstroke compared to the smooth ones here. There is some evidence to suggest that in septic patients, it's predictive of degree of renal injury and perhaps more importantly, degree of renal recovery. So that's the arterial side. The venous side, just to emphasize again from the VEXAS score, normal venous flow is continuous, minimal variation, and as it becomes more and more congested, it becomes more pulsatile and discontinuous. This is an interesting paper which has only recently been published, so I'm going to highlight this, done by colleagues mostly in Italy. And essentially what it does is to look at both components simultaneously. So a normal resistive index with normal venous flow, all the way to a high resistive index and pulsatile venous flow. And it predicts the occurrence of complications. In this population was laparoscopic urological surgery, but the concept I think makes sense. So watch this space for future development. Finally, around the microcirculation, I think by and large, people have realized that the microcirculation is important, but the stumbling block is around, is there any specific treatment to improve the microcirculation? There are lots of things that you can do to assess the microcirculation as listed in this slide. So you can look at capillary refill time. Probably the one that has the most research interest is the sublingual microscopy or some form of video microscopy. But it's not very practical on a day-to-day basis. So this is something that I know colleagues in Amsterdam and Holland are interested in. From a practical perspective, I think there are still challenges. So what I thought I'd talk about, continuing the theme of ultrasound, is contrast-enhanced ultrasound. So our cardiology colleagues, our radiology colleagues have been using this for a while. It's a intravascular agent. It's the size of a red blood cell, so it flows within the microcirculation. It's respiratorily excreted. Radiologists use it to outline vascular tumors. Cardiology uses it to delineate and clearly outline chambers. We've used it in COVID to demonstrate areas of infarct in the lung for patients undergoing COVID. But our more recent interests are around kidney perfusion. So this is what a contrast-enhanced ultrasound scan of the kidney looks like. So this one here is what you will recognize as a normal kidney ultrasound. And this one here is what contrast-enhanced ultrasound would look like. So as you can see the flow light up the whole kidney. And there are two things, broadly speaking, that you can measure. You can measure how quickly that kidney lights up, and you can watch how much it lights up. So that's normal. This one here, I hope you can appreciate, it doesn't light up as much, and it doesn't light up as quickly. This is a normal healthy volunteer. This is a patient who is septic. So it doesn't light up as much, and it doesn't light up as quickly. Early work from colleagues in my department have shown that we can predict the degree and recovery of septic patients who develop AKI by looking at this parameter, how quickly it lights up and the extent of which it lights up. And that's the paper here by my colleague and good friend, James and Sam. Kate's one of our renal physicians here at King's, and Dean is one of our radiologists, okay? It's much more accessible compared to a microscopy, certainly less user dependent, and that's why we think it has got potential. Some colleagues in France are also doing the same thing. So, and this is the name of the person who you should search under if you're interested in the use of contrast-enhanced ultrasound. Jacques Duranteau is a friend and colleague who works in Paris. Canins has done a lot of the work around the microcirculatory, especially around the sublingual microscopy. The big problem with microcirculatory assessment is that once you've diagnosed it, our therapeutic options are limited. In that particular paper, this one here, it outlines a couple of strategies that you can think about, but there is no, unfortunately, wonder bullet per se that can improve the microcirculation, at least in normal clinical practice. One of the last papers I'm going to put to you here is that when you can, a nice way of approaching hemodynamics, especially in the context of AKI, is to think about perfusion, and you think about congestion, okay? Ultrasound can give you a bit of information there. This is a very nice review paper by, again, colleagues from Italy and Canada. Susanna's based in the Brompton. Nice areas where they talk about assessing perfusion to the various different organs. Renal resistive index, I've told you there, LVVTI. They talk about transcranial Doppler as well. And on the other side of things, congestion, they talk about some of the concepts I've introduced here, diastolic dysfunction, hepatic vein, renal venous Doppler as well. So as a cell, if you've got a patient with AKI, I think it's almost mandatory that you perform an ultrasound. And I hope I've shown you that a lot of the skill set is within your ability to do. These are a couple of reasons why you should. And I close off by sharing with my email addresses. So if you want to collaborate or have any questions, I'll be happy to take them. Thank you very much for listening. And that's it.
Thank you, Adrian. That was an excellent talk. I mean, it was a masterclass on renal perfusion, I would say. And I like the way you classified them from the arterial side, the venous side, and the microcirculation side. Quite a novel concept, and clearly, you know, it makes the understanding much more better. While Tapas is collating all the questions that has been asked on the chat, I thought I'll go ahead with the first question, or rather, something that popped up as you were presenting your slides. I was just curious to know, Adrian, to more about the renal resistive index, which you had mentioned about. How much do you think it's a marker of, say, a global outcome in critically ill patients, and what are its limitations?
So I think so when I refer to the renal resistive index in this case, we're talking about the renal resistive index within the parenchyma. So you're not measuring the main renal artery. I think the utility of the main renal artery resistive index are usually classically for renal artery stenosis and transplanted issues when you're grafting it. I think the issue within the intraparenchymal one is very interesting because it is perhaps one step away from the microcirculation, and so that you can see further downstream what the flow into that kidney is like. The early work seems to suggest that, again, it is useful to predict those patients who are going to develop more longer-term problems rather than short-term hits. So simplistically speaking, if your intraparenchymal renal resistive index is normal and you've got an AKI, chances are that you will recover your function. The real question is, if you see someone with an abnormal renal resistive index and intraparenchymal stuff, how much can you intervene? So is there something you can do or not? There is some work out there to suggest that if you see that, it's not so much the value that's the key, it's what happens to the whole thing in response to therapy. There's a couple of case series that have used it to look at the ability to try and perhaps you've given too little fluid or squeezed too much, you've changed it, you've gone back, and the renal resistive index have gotten better. That, I think, is where the utility probably lies, rather than a single snapshot, this is good, this is bad.
Very nice. And yeah, Dr.
That was-
Ramanathan, any questions? Yeah, yeah. So, Adrian, that was simply outstanding. And I must thank you to comprehensively explain the nitty-gritties of the kidney perfusion. There is a question in the chat box by Dr. Praveen. As you mentioned, IVC ultrasound can be misleading in many circumstances. So do you see or do you use IVC ultrasound in daily practice? In which situations it helps you?
Okay, so I do use ultrasound of the IVC. I just do not use it in isolation. Okay, so the paper I referred to, and I'll put a link on the chat as soon as this Q&A is ended, to the limitations of the IVC. So I do not use the IVC by itself, and I don't think anyone should. Because when you're looking at the IVC, all you need to do is to tilt the probe slightly that way, and you're already at the subcostal forechamber. You already have a good idea, or you have an opportunity to assess the RV, LV, size, and function. So never interpret the IVC by itself. The other thing I would say is that traditionally, we have always assessed the IVC in its long axis as it flows through the liver. The problem with it is that we assume that the IVC is circular. If you speak to our radiology colleagues, they will say, well, the IVC is not circular, it's elliptoid, so it's oval in shape. A more accurate way of seeing a distended, non-distended IVC is probably in its short axis, so when it looks oval. So there are limitations. I'll put a link on the chat as soon as we finish my session. But I do use it, but I don't use it in isolation.
Yeah. Two quick questions just before finishing. One question is again from Surkata from Indonesia, that when situations where inferior vena cava ultrasound may fail to accurately predict fluid responsiveness, which are the situations? Yeah.
So I think if you've got someone with raised intra-abdominal pressure, so Professor Manu Mulbrain, who does a lot of the work on it, will probably be very proud of me for mentioning it. So when you've got raised intra-abdominal pressure, that's when your IVC is less limited. Limitations, again, when patients are purely speaking, the evidence is for mechanically ventilated patients. So patients who are spontaneously breathing, in pain, so on and so forth, it becomes less accurate. Yeah. So broadly speaking, those are the two.
Yeah. And the last question to you before we move to the next one, how do you use renal ultrasound to assess the improvement in a patient with AKI?
Okay, so what I've done in this talk is intentionally focus on the kidney because we're nephrocritical care. But the way I tend to think about perfusion is perfusion as a whole. So I start with the heart, I look at what the cardiac output is, and then I look at the various different organs. So kidney I use because it's relatively easy compared to all the other ones. It's moving away from blood pressure per se to flow. So when I look at the kidney, if the renal resistive index is high, for example, I would think to myself, am I over delivering the vasopressors? Does this patient need more fluid, so on and so forth? Do something and then go back and reassess that number. So in some patients, so we do see transplanted kidneys, I'm sure you do as well. So if a transplanted kidney comes and your renal resistive index is very, very high, the question you should be asking is there anything I can do to improve the perfusion to that kidney? It's not the baseline, I think is important, it's what you do, the therapy that's important. And because ultrasound, you can repeat it, it's almost like a monitoring tool.
Yeah. So Adrian, very well explained.